Welcome, everyone. Please note that this webinar is being recorded for future placement on AAG's website and YouTube channel. All participants are muted. Please place your questions using the Q&A box below your screen for discussion with the speakers after all three presentations have completed. Now over to our chair, Marlene.
Good day, everyone. I'm Marlene Rossick, a proud member of the board of the Alberta Association on Gerontology. AAG is a member-based organization focused on policy advocacy and practice change for a future of healthy aging and quality of life for older adults. Members come from across Alberta as older adults, caregivers, care providers, organizations, educators, researchers, and students. We acknowledge our presence in lands across Alberta and respect this heritage for our province. We are committed to an environment of dialogue and learning together for the future. AAG is particularly pleased to sponsor this Future Policies Forum program with initiatives to foster shared understanding and action for transformative change in support of the vision for healthy aging in Alberta and the opportunities we have to make significant differences in systems and services to this end. Check us out on our website. So welcome to the first webinar in our Future Policy Forums program, Transforming Continuing Care to a Culture of Healthy Aging and Quality of Life. We are very pleased that we have over 250 participants today to learn together and with three speakers well qualified to describe the journey ahead. The Futures Policy Forum webinar series, 8 in total, is outlined on our website. This is made possible by a number of financial sponsors whom you have seen on the opening slides. I am pleased now to ask one of our platinum sponsors to make introductory remarks.
Good afternoon, everyone. My name is Wayne Morishita, and I'm the Executive Director of the Alberta Continuing Care Association. ACCA members include both nonprofit independent owners and operators across the spectrum of continuing care, including home care, supportive living, and long-term care. We are very pleased to be a platinum sponsor of AAG's webinar series, as well as a member of the Stakeholder Collaborative Committee guiding the Futures Policy Forum program. I'm really looking forward to this webinar. Thank you.
Thanks, Wayne. It is now my pleasure to introduce our first speaker, Vivien Lai. Vivien is a long-term leader for continuing care, most notably in her many years as Executive Director of the Continuing Care Branch in Alberta Health, and now most recently as a consultant to Myers Norton Penny in their work to develop the report, Improving Quality of Life for Residents in Facility-Based Continuing Care. And for ease of reference, that links to this report were sent to you with your registration. Vivien will speak to you regarding the drivers and evidence for change in Alberta's system of services for older adults, as outlined in the MNP report, and implications for change.
Good afternoon, everyone. I'm very pleased to be here today to present on the topic of transforming continuing care to a culture of healthy living and quality of life. I'm speaking here actually in two roles. First, I'm speaking here as a sociologist and a gerontologist that have done a lot of work on aging research and policy. Last year, I was invited by MMP to join the consulting team as their long-term care expert for the Continuing Care Review report commissioned by Alberta Health. Thus, I'm speaking from the experience and learning I have gained from the research finding of this report. Second, I'm currently the chair of the Alberta Association on Gerontology Futures Policy Forum initiative. So I want to share with you on our future plan for this project. Next slide, please. Transformative cultural change are needed in Alberta for the continuing care system for many reasons. First, Alberta population is aging. By 2046, 1 in 5 Albertans will be over 65 years. Although we are relatively a young population, we have the highest growth of aging population in Canada the next 10 years. This new aging population, called baby boomers, are very different from the current generation of elderly. They desire independence and choice, and they prefer to age in the community. Especially after COVID-19, most of the older adults prefer to age and get services in the homes. They value the quality of life and want to have a choice in the methods services are delivered to them. In addition, the population in the future facility-based care will be changing. There will be more complex care and dementia care clients. Trained workers are needed to address their needs. Next slide, please. Working conditions of senior care workers also need transformative changes as well. Insufficient funding for staff shortages, low wages, and poor morale are issues that have to be addressed. The living environment of continuing care facility also require transformative changes. Residents want to have private rooms, 4-bed wards, share rooms, facility with poor ventilation have to be eliminated to stop the spread of infectious disease. Now, I do want to point out that above issues facing the continuing care system in Alberta is not unique. All the provinces in Canada face similar issues one way or another. Funding and improvement of seniors care system is an issue I think all Canadians have to address. Next slide, please. In 2020, Alberta Health commissioned a facility-based continuing care review to make sure that the continuing care system is modernized to respond to the changing needs of society. The study was conducted by the MMP firm and then surveyed and interviewed the public, families, residents, staff, policy planners to find out their preferences for the future system. The sample size is 7,098. This is a very large sample size. Collectively, what the respondents have told us is that they want transformative cultural changes in the continuing care system. And they think it is needed to equip the system to address future needs of the Alberta's aging population. Next slide, please. The survey asked the respondents what opportunities are needed to improve the quality of life of facility-based continuing care. They collectively told us that we have to shift the culture of care from a clinical task-oriented medical model to a holistic, relational, person-centered model care. They want more recreational opportunities. They want an increase in quality and variety of food. They want the design of facility to provide more space, eliminate share rooms. They want to increase opportunity for family visits, reduce social isolation, and they want to improve access to technology and internet and culturally sensitive senior services. Next slide, please. We also asked the respondents what opportunities are needed to improve the quality of care and support for the continuing care residents. The respondents asked us to improve the continuity of staffing assignments. They want to have consistent staff looking after them instead of staff rotating too many times. They want to have increased access to therapies and mental health. They want to be involved in care planning, and they want long-term care space closer to their homes, particularly for indigenous and rural areas, and they want frontline staffing. By the way, all my quotations here are based on the interviews, from the surveys and the interviews. Next slide, please. Choice was identified as the most important dimension of quality. How do you improve choice? They want greater focus on aging in place. They want to provide options for clients to choose to receive care at home, in the community, if they choose not to be admitted to a long-term care facility. They want the focus of care to shift from task or orientated care to quality of life care. They want clients and caregivers to be members of the care team. And they want the facilities to be flexible in design to meet the client's needs, like to have smaller homes or let couples live together. Next slide, please. Clients also want to have a choice when their services are provided. They want to have a choice in food, mealtime. Food preference is important, particularly for cultural and religious reasons. They want to be able to decide when to bed, when to wake up. They want to have baths at the time they want it and how many baths they want to decide. And they want to be engaged in social activity, such as participate in religious activities. These are the choices we have at home. And the residents are telling us they want the same choice as well when they live in the continuing care facilities. Next slide, please. So based on the suggestion in the research and the findings, the MMP recommended the following to be the vision of healthy aging in Alberta. Albertans are supported to be healthy and active in the community with an improved quality of life, and they are engaged, empowered, and enabled to live inclusive communities with social connectedness and healthcare access. Next slide, please. This report suggested 3 tiers of policy to be developed to achieve this vision. This looks like an inverted pyramid, with the base being the most important one. As a first level to achieve healthy aging, the report suggests government must have population health policies addressing the social determinants of health for the population, including good eating habits, healthy lifestyle, provision of programs to address housing, financial, and social security needs, primary health care, prevention programs, age-friendly and dementia-friendly communities should also be available. In the second level, extensive integrated community-based networks and systems must be available to look after people with moderate and complex health needs at home and in the community. Innovative programs such as nursing home without walls, smaller homes, neighborhood service hubs, intensive home care, and self-directed care could be options for consideration. Lastly, facility-based care should always be available to persons with high health needs. The emphasis should be the quality of life for the residents. Next slide, please. So the report proposed to have transformation in 4 major areas. The first is care for the residents. They are the client or the focus of all our services. Second is working conditions and training of the staff. Third, the living environment for the residents. And lastly, governance and management of the continuing care system. Next slide, please. So the recommended changes for the care for continuing care clients are as follows. Establish quality of life as the #1 priority goal for Alberta's continuing care system. Deliver compassionate, relational, person-centered care. Support couples living together while in care. Include caregivers as essential members of the care team. Enhance quality of care of the dementia residents. Make service culturally sensitive to needs of different groups, respecting the food, language, and ceremonial traditions, and improve navigation and service coordination. Next slide, please. Increase the hours of care for continuing care facilities from 3.4 to 4.5 worked hours for direct personal and therapy care hours in long-term care facilities. Comparable increase were also recommended for designated assisted living sites as well. Expand choice available to Albertans by introducing a new program called self-directed care. This program is available currently now in many countries in other parts of the world. Clients can choose location, types, and providers of services in this program. Expand home care service substantially to provide intense home care service to persons with high complex health needs, and optimize the use of technology and innovation in the delivery of senior services. Next slide, please. With regard to working conditions for staff, the report suggested that a workplace improvement action plan be developed to enhance the working condition for staff both working in the facility and home care. A provincial resource strategy for seniors workers should be developed to make sure we will have sufficient staff to address the future needs of older Albertans. Labor force is the major issue facing continuing care as well as the health system. And then it's the issue we must address in future. It's also suggested we transform the workforce design, culture, and working condition for senior services workers. Next slide, please. With regard to living environment for facility-based residents, the report suggested that long-term care facilities should be redesigned so that it is a real home to resident, not just a concrete building. Smaller homes, campus of care, and new models of care are the preferred models of care. The building guidelines or the facility-based continuing care should be adjusted to avoid future spread of infectious disease and pandemic. Next slide, please. Relating to governance and management, the reports recommended the government should consolidate the monitoring activities. Accountability, public reporting, and enforcement should be emphasized. And Alberta should ensure that the future of the continuing care system is sustainable and affordable. Next slide, please. Alberta Association on Gerontology supports the recommendations of the MMP report. And we created this future policy forum for the following reasons. First, we want to promote public awareness on the need to transform the system, as well as to provide an opportunity for the public to be involved in this discussion. Second, we want to create a community of cultural change with change champions and leaders to assist in the change. The Futures Policy Forum will include monthly webinars, engagement sessions, think tanks, which you can choose to participate. They are all free. Next slide, please. So we welcome your participation in this Futures Policy Forum. You can register for future sessions by going to our website. We welcome you to participate as a change champion to help us to transform the current system. We appreciate and value your contribution. Thank you very much for listening to me, and I would be very happy to answer any question you may have.
Thank you, Vivien. I'm just struck as you by the helpful nature of your slides to overview the MNMP report and make the changes we need to see very concrete. There were I'd like to comment on two questions that were raised in the Q&A. One, the question of slides being available. We have committed to record these sessions and they will be available on the AAG website under the Future Policy Forum and our YouTube. And I will commit to follow-up discussions with the speakers regarding the availability of the slides. The second comment was made about, in Vivien's slides, we want a dialogue. We do want a dialogue, and encourage you to place questions in the Q&A so that we are aware of them. I did answer a couple of them, the ones as we were going, but place them there because we want to pick them up at the end. This is a desire for dialogue today, and also the post-webinar survey asks for your input around priorities from your point of view. We are also working with our panel and our stakeholder collaborative committee, which is a group of 36 leaders in the province, to think about the best way to create ongoing dialogue through the AAG's website. There's a special section, Future Policy Forum, component of that website, and that is the best resource about follow through and continued opportunities to follow the new developments beyond the webinar as we get there. So look forward to your questions. You can ask them at any time in the Q&A. We are monitoring them. Some I answer directly, some we will pose to all the speakers at the end. So it is now my pleasure to introduce our second panelist, Dr. Carole Estabrooks, Alberta's own nationally recognized gerontology researcher. Carole has a track record of research and advocacy for better care for older adults and better workplaces for caregivers with her research organization, TREC, and her participation in a range of provincial and national committees for change. She was also a member of the expert panel for the MNMP report. Carole will speak to the importance and urgency for change.
Great, thank you very much, Marlene. I think my slides are up and my voice can be heard. So thank you for the opportunity to talk today. My theme is really going to be transformation. It's complicated, it's still doable, and it is exciting, but I don't want us to underestimate the complications that we're going to encounter and not to lose heart as we press forward. I'm going to talk about the major recommendation that come out of the Royal Society report in mid-2020 about the impact of the pandemic on long-term care, not because it was about the pandemic, but because it was exacerbated from years of this workforce issue being a serious and growing problem. But in talking about that, I'll talk about some of the things around it that we need to pay attention to. I know we all want to live in a place like this, or a place like this. This is my personal favorite. And the question is, how do we get there? How do we get to these small living environments where people have meaningful activities in their lives, where there's community and connection, and they begin to be able to stack up even with advancing and advanced dementia moments, quality moments that will result in people having a good life at the end of life. I will speak mostly about the highest level of care in residential long-term care, but of course, everything that's done everywhere in the system has an impact on everything else. So if home care and assisted and supportive living are challenged, we will feel it in long-term care. If long-term care is challenged, vice versa. So we have to think of this as an integrated system. Because the MNP report and every report I've read, including the Royal Society report and the 50 or 80 we read to put that together, talks about quality of life having primacy. This should be the primary goal, the goal that drives everything in all our continuing care locations, and certainly in long-term care, where we will see people with advancing and quite severe dementia. And I know that many of you know this, but it is possible to have good quality of life with advanced dementia. It isn't a sentence for a hellish misery. It can be, but it doesn't have to be. We have lots of incidences around the world where people are achieving this, and we have incidences in Alberta. Some of you are on the call where your environments are able to support that. But quality of life is complicated. It's about one's feelings about it. It's about your mental, psychological, social well-being. It's about behavioral competencies, which are functional capacities. And it's about the quality of the environment in which you work or live, depending on whether you're talking about the staff or the resident. This is just another way to say some of the same things. Most of the factors that are linked to poor quality of care and to better quality of life and to better let me rephrase that. Most of the factors linked to either poor or better quality of life are significantly influenced by care processes, care relationships, and the care environment. As my colleague Pat Armstrong would say, the conditions of work are the conditions of care. So it's really important that we look at this holistically. Some of the things that happen to you as you have advanced dementia aren't as modifiable as when you had earlier dementia, but people do not have to suffer the way that they sometimes do in long-term care settings that are struggling. So I'm going to talk now about the workforce, but I'll shorthand it and talk about meeting staffing needs. To find the formula for the right staffing needs, and I know that many provinces, and certainly Alberta has a formula, and we base it on resident characteristics, but that's insufficient, I would argue. We have to have clear profiles of residents and their dependency levels. And in Alberta, we're all used to seeing CMIs, but we also have to have profiles of the workforce that's looking after them and profiles of the work environment in which people live and work, and an understanding of how they interact. Houch wrote a really nice paper last year. It's at the bottom here about this. And my paper is basically a summarization in shorter hand of her work. to say that we have to tackle this complicated issue of the workforce with more than single strategies, not just hours of care, although they're fundamentally important. In terms of resident profiles, we have pretty good data on care quality. We don't do as well looking over time at how things have changed and how they're moving in response to things that we do. But nobody in the country, nobody in the world that I'm aware of, and that doesn't mean that it doesn't exist, systematically collects subjective resident quality of life, which is arguably the most important thing to have. Because if you can't measure something, you can't manage it. If you don't have any idea whether your quality of life in your homes is going up or down, then it's hard to know if the things you're doing to try and improve it are working. And of course, we have tremendous gaps in how we understand diversity amongst residents. This is an example of what you can do with the RAI data. Some of you are places that do this kind of thing. This is important. This is a good news and a not so good news story. It shows a plummeting length of stay in Alberta over a fairly lengthy period of time from 2008 to 2015. And it shows a rising length of stay in Winnipeg, and that's a function of them having people in their homes that shouldn't be there, that don't require that much care. That is successful from the perspective of keeping people at home longer and bringing them to nursing homes later, so they have shorter time in the nursing home. But with that comes, don't be put off by this. It's really basically what this says is when you do that, when you bring people to nursing homes later, they have more cognitive impairment, which is the bottom left graph. And in the top right graph, they have heavier needs. They're more dependent. They can't bathe and dress themselves as much and feed themselves. And in the bottom right, you have a higher CHEST score, which is a stability measure, which means that when your CHEST score is over 2, it tends to be a rule of thumb that you're probably within 6 months of death. So all these scores have sharply increased in Alberta's nursing homes. However, we didn't change the basic workforce as we did that. There was a bit here and there, but we didn't make wholesale changes that would help us match that. And that's part of why, and it happened right across the country, the pandemic was so painful for everybody. It's not the whole story, but it's part of it. Most provinces, and I'm going to talk about the work environment now, have kind of structural data. They know ownership and profit status and age of buildings, but that's not the work environment at the point of care where the resident is. We have evidence broadly, and we have Alberta-specific evidence that the work environment influences care and work life. I'll just give you a couple of examples. When we measure physical and mental health in care aids in Alberta long-term care homes, we find that people working in green homes, which are homes with a more favorable work environment, have higher scores on physical and mental health. So it looks to us like maybe if you improve your work environment, you can improve really hard to move things sometimes like physical and mental health. That's very exciting from a change perspective. When you have residents and you measure their quality, you measure symptoms toward the end of life in the last 12 months. It goes from 12 months to death, left to right. And this is just 2, shortness of breath and pain. Those symptoms go up, and they don't necessarily have to, but they do go up as they do in all jurisdictions I've seen. But if they're living in a green home, a home that has a better work environment, they have fewer symptoms. So by tinkering with the work environment, you can lower symptoms, and that has to do with the care process improvements that happen when you improve your environment. And then staff profiles. Data are limited for all workers in long-term care, but especially care aides. We don't even have basic demographic data and data that tell us about the diversity in this workforce, although I can tell you that in Alberta, only 17% of care aides, 17 to 20% of care aides are white and have English as a first language. So you know just from that one stark piece of data that this is a tremendously diverse workforce. It is culturally and racially complex. It's almost all female, a little bit older than some health workforce populations. And we have to think about those things when we're designing programs, for example, employee assistance programs. Nobody has data. We have only in research studies do you have data on quality of work life and their general health. And we don't have any on mental health and well-being, except in research studies, although we will see more post-COVID because it's a mess out there. I mean, COVID's had a tremendous impact on mental health and well-being. And I want to make a caveat here. Recommendations for hours of care and skill mix, that what kind of different workers should you put together? While they're limited, they do exist. But reader in the United States, that all it is, we would this 21 years have changed radically. 4.1 hour is a start at the end. Off the record, who've been doing staffing in the States say for highly skilled nursing home care, which is what most of our long-term care is, it's 6 or 6.5. He gasps and says it'll the country. That's what's needed, rather than saying it's ridiculous, it can't happen, their data wrong, they don't know what they're talking about. We say all kinds of things when we find a piece of hard. We need to say, okay, 4 months a start. What can we do about the plant? What can we do to maybe offset the needs? And why don't we get some kind of an assessment in Canada in 2022 or 23 that says this is the level below which quality will fall no matter what you do if you don't have these hours of care. So lots of work to be done there. This is about the workforce pre-pandemic. The nursing homes in Alberta were long-term care homes. We're working with a population. I'll just pick the care aids out from the top bar in each of these three things. The top two are bad for burnout and the bottom one's good. We're working pre-pandemic with a care aid workforce of whom 50% were at high risk for burnout before the pandemic. I think one of the plausible explanations for why we didn't have more difficulty, and not that it was easy, with these high levels of burnout risk, was that the care aides and others in long-term care bring a really strong sense that their work has meaning and value, and it's important and necessary. That may be working as a buffer, but you can't exploit a buffer forever. And we'll see what happens when we start looking at the post-pandemic data, because we'll have these same measures. I know for some groups that I've already seen, it looks worrisome. And I want to just make another punctuation point about burnout. We all talk about it in our regular language. Oh, I'm burnt out. Oh, I need a vacation. I'm burned out. Real burnout is a state that's persistent. It's not a come one day and gone the next. It's argued, my colleague in Calgary would say, she would argue that it causes reduced compassion satisfaction, which is essential for care workers. Whereas traumatic stress, which is something like the pandemic would cause, that may be a super big traumatic stress. She would argue that compassion satisfaction remains high and that's a more transient state. Now we'll see over the next while. We have some research going on that'll help us tangle this out. But what I want to say is that you had this traumatic stress on top of this chronic, very difficult to recover from state called burnout. So we have to watch that carefully. So how do we get to nice, cool places where people have good quality of life, and small facility living and choice and freedoms and all the things that the reports that MNP did and others have done across the country argue for? Or, well, we don't have one of these yet, but we have the right province to have an equine-based facility. And there's really exciting research coming out of veterans and beginning really super slowly with older adults about the effect of pets in general, but not just random pets, like pets in programs that help people with dementia reestablish connection. So what do we do going forward? We have to address the workforce. And I've given you some kind of meso and micro level things, but we've got to have a workforce strategy. If 80% of your workforce are immigrants, and at least in the care aid group, that has really significant implications for a strategy. This is a problem across the country, but Alberta will have its own unique take on it. So that would be my urgency, would be to address the workforce, find ways. We have to, because if we don't, it's like trying to give psychological care to someone who doesn't have the ABCs of life support in terms of air and breathing and circulation. Thank you very much. Happy to take any questions at whatever point that makes sense.
Thank you, Carole. You've made a really compelling statement about the urgency for workforce. And I was watching some of the comments, so there'll be an opportunity in the Q&A to pick up some areas that are important to people. I want to share with you that future that Vivien spoke about, a future for healthy aging and quality of life for people, is actually with people who also want the same things about quality of life for themselves. So put in your mind 2 follow-ups to this, and this is how we'll try to follow on your input on the Q&As here and any others and your survey feedback. We have a webinar on June 15th, and it is focused solely on workforce and workforce innovations, and Carole will be speaking again. And we have others, so you'll be seeing that very soon. And that commitment on the workforce as priority is also translating to a focused think tank to be developed in the fall, again on workforce. So a continuation of that priority focus. I want to address one other thing because I've been really pleased to see the Q&As. I'm going to ask our host Jordana to speak to the fact that it's really important for us to get your input through the Q&As and why we have disabled the chat with our best efforts to try to facilitate this. Jordana.
Thank you, Marlene. The chat has been disabled for attendees to allow us to direct all questions into the Q&A to make it easier for our speakers to address questions as we go throughout the presentations. If you have any comments, you can add them to the Q&A as well. And if you would like to engage with other attendees, you are able to upvote questions and comments in the Q&A by hitting the thumbs up button. You can also add comments below other attendees' questions or comments in the Q&A section. To access this at the bottom of your Zoom screens, just click the Q&A button. You can also view all answered questions, clicking the Answered tab within the Q&A screen. So if you have any questions about an already answered question, you can view those there.
Thanks, Jordana. We will also be getting AAG, that is, we'll also be getting a transcript of all the Q&A, the questions and the answers, and we have a writer that is following the theme so that we can not lose your input, but build on it. So we're now ready for our third presenter, and we're very pleased to have Alberta Health contribute to this presentation with an update of their work to examine the MNMP report and plan the way forward. Certainly, international best practice is change happens best when government is part of the collaborative work with organizations, with people. And we're really pleased that Alberta Health is doing that. They're a member of the Stakeholder Collaborative Committee advising on the Future Policy Forum. And now we have Evan Romanow, Assistant Deputy Minister for Health Services Delivery, to share what they are doing. Over to you, Evan.
Great. Thanks so much, Marlene. It's a pleasure to be here today, and good afternoon, everyone. I am really excited to share updates, and I know a lot of questions in the chat were asking about what Vivien was highlighting, and Dr. Estabrooks with work underway and research. There's been a lot of talk about the needs for transformation and action, so I'm very pleased to be able to share a lot of the significant updates that are underway to really recognize the needs across the continuing care system, a rapidly aging population, but most importantly, to focus on the right elements to design the system to support that population going forward. If we go to the next slide, please, I'll just give a little bit of a quick background and go into the following slide. Just again, what we're specifically speaking to with continuing care and really some of the most important work on the following slide. Jordana, please. Perfect, thanks. So really, as we're talking about continuing care, I think it's important, and for too long, we've actually talked about siloed elements. We talk about independent living and supportive living environments very separately from palliative and end-of-life care. It's important, and a lot of the work that I'll speak to a little bit further relates to how we're actually trying to design the system in a more coordinated way with better referral pathways and better interconnection between different elements of the system. I think certainly the most important area is the lighter touch sets of interventions, as you'll see on the left-hand side, in home living, which really refers to people who live in their homes or apartments or condos and receive some assistance, whether by friends or family or home care programs. There in last year were about 118,100 Albertans who received home care services, and that's growing roughly 6 to 8% a year. And really, as Vivien spoke to, a big focus of work going forward is to emphasize and reinforce the supports in this area to provide those lighter touch supports to be able to keep people where they'd like to continue aging for as long as is possible. Supportive living is congregate setting that combines accommodation services with other supports and care. Further along the spectrum, continuing care homes, so that's currently designated supportive living or long-term care. Roughly 4% of Alberta seniors age 65 plus do reside in a publicly funded continuing care home, and approximately 91% of DSL or long-term care residents are age 65 plus. And then importantly, as I referenced, palliative care is really important to be able to provide supports in various settings so that Albertans can experience dignity and comfort in the final stages of life. And really the focus, and you see where dollars and allocations and the number of individuals served are in this system, really wanting to have more coordination going forward. Going to the next slide, though, it is significant in Alberta, the pressures that the system's facing. Vivien spoke to this earlier, but in 24 years, the number of Albertans will double, and very significant as it relates with pressures in the healthcare system. The so-called 565 related to an aging population, 65% of healthcare costs are attributable to 5% of the population. And 3/4 of this 5% are frail, elderly, or older people with 3 or more comorbidities. And so it's really important to look at who requires supports, how do we support people at the right levels, but recognizing that we are going to face considerable pressures going forward. And most importantly, we want to make sure we're responding in the best ways to meet the needs of Albertans. Looking at the next slide, our system is complex, and every time we add something new, we do add to the complexity, we're well aware. Certainly, though, a big focus in the facility-based continuing care review is that reminder that we need to look at system navigation. I talked about those different elements of the system, but how do we have better interconnections? As well, a big focus and pressure in the system, as was referenced by both previous speakers, is on the staffing challenges within the sector. COVID absolutely has made it worse. We have incredible workers across the system, but they're tired and we need more of them. And so how do we strengthen the workforce going forward? And that ties into sustainability of the system, making sure that there's the right funding going forward and right funding in the right areas. We saw over a 6% increase in funding this year, significant government investments to continuing care, but we need to make sure that there are the right supports going forward. And I think importantly, talking about those lighter touch interventions, as we see investments for home care where Alberta has lagged behind other jurisdictions, it's important to be able to provide the right supports in the right places. Going on to the next slide, again, COVID absolutely, and this will be news to no one, has highlighted issues within the continuing care system, but really a lot of these issues aren't new. COVID absolutely and very unfortunately increased social isolation and mental health challenges for seniors and caregivers, both in community as well as in continuing care centers. And that's absolutely had a lasting impact, and it's something that we need to respond to head on. Albertans, we know, and individuals in general do fare better in private rooms, and needing to look at the infrastructure that's in place to be able to support that type of requirement, again, for wellness as well as health and safety reasons. And we really need to look at that as it relates with capital planning or replacing older sites going forward. But then there are also systemic staffing challenges, as mentioned, as it looks at differentials between wages, different types of part-time versus full-time employment considerations. All of those elements during the pandemic were highlighted and are absolutely front of mind in the response plan that government has as it relates with the facility-based continuing care review. Going to the next slide, despite these challenges that are being faced in continuing care, we're absolutely fortunate in Alberta to have very strong foundations in many regards, and this will let us build off of a lot of positive areas and enable us to meet challenges and demands moving forward. We do have similar quality across all operator types in facility-based continuing care. We're very fortunate to see, and we saw this throughout the pandemic, high quality of care in public, nonprofit and private providers. And that's not something that we've seen elsewhere in other jurisdictions. So we've got very strong and capable operators delivering high quality care. Alberta seniors also have significant benefits through the Alberta Seniors Benefit Program, which offers the highest income thresholds and the highest benefit maximums when we compare to other provinces. And so that support to go into continuing care or to stay independent, we have the highest benefit levels as well in a corresponding way, the lowest poverty rates for older Albertans. And there are also very consistent standards which are required across different ownership types and very strong and ongoing monitoring in those facilities. We saw this again, the high focus of compliance and monitoring throughout the pandemic, very active monitoring to make sure that health standards were being followed. But we also see, because of the high standards, Alberta also performs very well with different quality indicators. One example is the use of antipsychotics in long-term care, where Alberta has been lower than the national average for a number of years in the inappropriate use of antipsychotics in long-term care. We're also moving forward with the elimination of shared rooms, and this is one of the recommendations from the continuing care review. And we're, I think, very well positioned because of this work, and this is such a significant piece, the partnerships which are in place, working very collaboratively with residents, with families, with industry, with Alberta Health Services and government, and that started during the pandemic, but is so strong, like through these types of forums, to be able to deliver work going forward. So let's talk about that work going forward with the next slide and talking about the continuing care transformation, and actually jumping one more ahead, please. The pillars from the facility-based continuing care review highlight transformation, which is really focused in these three core areas, and there are 42 recommendations underpinning these elements. It's important to note 42 recommendations, as Vivien outlined, significant amount of work in front of us. This is going to be, many months and years in the making, but the focus is placed squarely in a couple of these key areas, and the other recommendations will follow. The first is to increase the number of people receiving care in their homes and community. This is what people want, and it will also reduce pressures on the acute and continuing care system. It also will achieve cost avoidance, which enables bringing additional dollars and resources to critical parts of the system. The second, as mentioned, is increasing workforce capacity. And I think most importantly is improving the workplace environments for staff, which we know leads to better quality of care. And then based on the quality of care piece, absolutely to focus on resident quality of life for residents and their families, friends, and caregivers. And that prioritization of quality and safety is front and center. On to the next slide, just to show where we're at with this overall work. The first step was to enable through legislation, a foundation really to provide a framework for this action. This is just newly off the press. Bill 11, the Continuing Care Act, was introduced in the Alberta legislature on March 28th. This is absolutely a momentous achievement, and it's going to be a building block to move forward. Currently, continuing care services are legislated and overseen by 6 different acts, 6 regulations, and 3 sets of standards. And so it's no wonder that it's hard to navigate, and the system has lots of complexities. Some of this legislation goes back to 1985. And of course, we know that since 1985, a lot has changed, and no wonder we need to play catch up with the overall infrastructure. And so what the Act will do is remove barriers to implementing some of these key initiatives, the recommendations from the Continuing Care Review. It's really going to focus on outcomes and being less prescriptive and enable more flexibility for operators to meet the needs of clients and residents. And it's absolutely front and center focused on the quality of care in all of this work. Now, the important piece and a lot of the details in this work are going to come forward in regulations and standards, which are going to follow in fall of this upcoming year, fall of 2022. And then more standards coming into force as early as spring 2023. So these are a couple of the key enablers and the next steps on the legislative front. Going to the next slide to speak in a little bit more detail and why this legislation is so important. The legislation will eliminate barriers to implementing other initiatives, as I mentioned. Again, we have a lot of fragmentation currently. It's going to focus on areas like couples and companions with different care needs who are often unable to remain living together. They'll reduce barriers to supporting them moving forward. The current legislation also creates barriers in implementing innovations and delivering different models of care, such as small homes, which are recommended in the facility-based continuing care review. The legislation is aimed at being person-centered and flexible and innovative. And most importantly, that is to support the client and resident choice. Again, and there were some questions on the chat, it is strongly focused on improving transparency and accountability for clients and residents, but also to make it very clear for providers and operators regarding public needs and expectations. And then there's also the alignment, as I mentioned at the beginning, about to deal with inconsistencies between different parts of the system, be it palliative or designated supportive living or home care, to have that consistency across the system. And it does reduce red tape, making it easier for Albertans to understand and navigate the system. Going to the next slide, since 2020, we actually have made significant gains already in the continuing care sector. And this is despite the pandemic and strong efforts to make sure that safety is in place. In step with our other initiatives to support and expand palliative care, in May 2021, we included coverage for the costs associated with pre-filling syringes in the palliative coverage program, for example. There's stronger public reporting, and as of July 2021, audit results are now publicly reported on the AHS Continuing Care Directory. The continuing care design standards and best practices are in the process of being developed and will be released later in 2022 to meet better design needs and a lot of the lessons from the pandemic. We had just recently released a call for grants under the Indigenous Capital Grant Program, and announcements coming in spring 2022 this year to bring forward new supports in that space. And a continuing care facility directory to make it easier for Albertans to navigate, to identify which facilities are available, and search all in one place what options are available for aging. So those are some of the earlier pieces, and much more to come, as I mentioned, in the coming months and years going forward on the overall 42 recommendations. I think a very important piece as it ties in with, on the next slide, sorry, as it ties in to government's approach, we're trying to look much more at the needs in community, and although continuing care is supported through Alberta Health and delivered through Alberta Health Services and other partners, it's not just about health responses to supporting aging. It's so critical, and the facility-based continuing care review highlighted the need to partner with others in community, other organizations to deliver needed supports, and really, again, focused care in community. This includes organizations like the Alzheimer's Society of Alberta and Northwest Territories. We've expanded the Alzheimer's Society's First Link referral program to rural and remote communities, where families and caregivers can access services and learning resources to help people navigate those who are living with dementia. Caregivers Alberta, another very strong organization, funding to expand their supports and programs and resources for caregivers. The United Way of Calgary and United Ways across the province, work that the government has done to support a facility-based continuing care system and have broader interconnections with community organizations. On the next slide, and going very quickly, there's been very strong investments on the capital front to support additional needs going forward, over $204 million in capital funding over 3 years to modernize facilities. Supports will also be coming to look at small homes and more innovative practices. On the next slide, work has been placed in over $20 million in funding for palliative and end-of-life care, significant investments building on the Advancing Palliative and End-of-Life Care in Alberta report that was undertaken, and really talks about how we can expand research, innovation, community supports and services, and more in that space. The next slide, talking about the workforce, some immediate investments to support and expand healthcare aid education to build up the sector. The following slide, we have new client-directed care options, which starting in Edmonton on April 1st are available, and we'll be expanding for different options across the province. Expanding home care procurement and looking at additional home care solutions in community, and more to come on that in the next few weeks. So to conclude there, and with the final slide, and we'll open it up for broader questions, there's been so much work that is underway, so much more to come. I can assure you of that our team across the Ministry of Health, Alberta Health Services, and the Government of Alberta is focused on delivering on these recommendations, and many more details on the work to come will be informed by these types of forums. So thanks very much for the opportunity to present.
Thanks, Evan. That was a tour de force. We know change is required. We see a plan to make them, and we know from the Q&As there's more that we all need to do. So it is now over to the audience for your Q&As, and our host will facilitate the Q&A that we have noted, with our speakers providing the responses as best we can. And remember, we are recording this for the videos that will be on our websites. Second, we will have a summary of all the questions, and there will be follow-up on those as best we can. So over to Jordana.
Thank you, Marlene. Any questions you can place into the Q&A box using the Q&A button at the bottom of your screen. You can also scroll through other attendees' questions or comments. You can like them and upvote them by clicking the thumbs up button under the left-hand side, or you can comment on them clicking the comment button under the right-hand side. Going through the questions that have the most votes so far, this one is from Heather. For those of us who do not have formal leadership roles, but work in continuing care as frontline clinicians, what do you suggest for us to become change champions? I'll open this to the floor for any panelists who would like to answer.
Maybe I can speak to it first, but many other people can speak as well. The AAG Policy Futures Forum is actually designed specifically as a broad-based initiative, which will inform the public, but also work with a stakeholder group that will create change agents, change champions, and allow an opportunity for anyone that want to be leaders, this change to participate. So right now, our committee, the stakeholder committee, had 48 members representing different organizations. So, and we will have this forum monthly, but we will also have think tanks and other activities. So, and in our website, we're inviting people to write to us as well. So any one of you that want to be a change champions, for sure write to us, and one way or the other, we will figure out a way to involve you and empower you to lead the change. By the way, I've done a lot of research on creating a transformation. It's important. Government play a role in the change. Legislation is very important. But all the studies show that unless the people, us, the community, also lead the change and create to be change leaders, it won't happen. So I encourage as many of you to participate in this movement.
I could also comment, it's Marlene, the Stakeholder Collaborative Committee will be having a discussion in June at our, at our May meeting, where I will be bringing forward these comments that relate to the workforce and the ability to people in the workforce to contribute, because it is a conversation about organizational change for engagement and supporting working environments that work well.
Thank you. We will move on to the next question. This one is from Carole. How do you move from silos to an integrated system while allowing for the progressive stages that aging is without the barriers of reassessments, weights, and more weights? I will open this to the floor.
I can say one thing. I think that one of the strategies that might help us are campuses of care. If we do them well enough, I think they can help with people who want to locate on a campus where the care will be continuous. I must be 40 years ago. I had, and I didn't mean much to me 40 years ago. I had very elderly relatives say that in the States, they had to move to what we would probably call now supportive living. And they were so pleased because they weren't going to have to keep moving, that they would get to know people and they could live in a community and on a campus. So I think there's other things that Evan may want to talk about in terms of the legislative framework, but that's one thing we can concretely do. And especially if we think broadly about campuses of care, the obvious model is a bunch of acres where we create the campus, but there are other ways I think we can think about campuses of care.
I also can add something. I absolutely agree with what Carole said. Campus care is very useful for that. But the other one is to switch our thinking. I worked in continuing care for more than 30, 40 years. We always had this idea that we have this category of buildings, and we try to slot people into all this category of building. I think we should stop categorizing the buildings, and we should measure the needs of the people and go to a system I call money follow people. If people have this health needs, assess the packages services they want, and let them even choose where to live. That will be the ideal system. Now, it will take us a long time to go there. And the MMP report, in a way, is recommending us to respect. You remember what I said, client choice is the key dimension. Let people choose and let your service meet the needs of the people.
And I would just add, we've seen throughout the pandemic in particular how technology has enabled supports. Traditionally, it was said over the last years before the pandemic, no, virtual monitoring, it's going to be too hard for an aging population. Well, we've seen that's not the case, and technology is being embraced readily. So how can you look at, to Vivien's points, care in community and virtual settings? It doesn't mean exclusively, but how can you, especially in rural communities and other locations, do home health monitoring and different elements to have that connectivity, that social interaction, which is also so important, but not that same reliance on a facility to offer care. So I think there are different ways to re-envision what that community of care looks like in the future.
Thank you. The next question is from Jane, who's asking what the system is going to do on the physical side of facilities. How does the system renovate facilities so individuals don't have to share washrooms? The example given is 4 residents and 1 washroom in an SL3 facility.
So I could probably directly respond to that one from the government side. That was one of the immediate recommendations from the continuing care review that government committed to immediately undertake. And some of those exact rooms, dorm style rooms with 4 beds, those were immediately being phased out and moving into dual occupancy rooms. There were 200 immediate ones on the list, those dual occupancy rooms, very small, almost for one person. Those are being phased out now. That's through investments, the 204 million I referenced that government's allocated immediately, and looking at what future requirements are for modernization of other facilities. Those very directly we saw from an infection prevention and control perspective, that's essential to deal with the infrastructure issues. But I would add, Alberta actually fared much better than other jurisdictions, as we had seen in other provinces throughout the pandemic. We didn't see the same types of outbreaks and deaths because we actually have newer infrastructure. It doesn't mean that we can't continue to do better and modernize, and government's committed to that. But I think we're fortunate we have newer infrastructure, and the goal is to really exactly deal with those design requirements that enhance quality of life and certainly are safer moving forward.
Thank you. Deborah asks, what is being done at the provincial level to encourage youth to choose a career in healthcare, specifically rural continuing care, which is struggling with recruitment of skilled HCAs and nurses?
Yeah, we did include, and I referenced the $12.8 million, which was done just in recent months as a bursary program to support exactly that, the ability to encourage and support the financial barriers for young people, certainly for new Canadians, where the costs for tuition are a pressure, and to directly provide those incentives. But the bigger work, and this is pointed to in the continuing care review, is to take a system level assessment, and we're working very closely with advanced education and labor and immigration ministries in government to look at what the strategy for the overall workforce is, so we can attract. There's strong competition that we see with other provinces, but how we can attract and then, very importantly, retain staff through the high quality that they want in a work environment. And I think those are all key elements, connecting in with learning programs and spaces in post-secondary. All of those are important elements, and all of that's going to be part of our human resources strategy that's going to be developed in the coming months to exactly get after those pieces. But small elements like bursaries are some immediate actions that the government's taking to be able to encourage that workforce.
I would just add to what Evan was just saying, that as the, with the ACCA, we also belong to the National Organization for Long-Term Care. And we are working at a federal level with our partners across the country to get some, to look at different ways that on a federal level, they can work with the provinces in terms of enhancing the ability of foreign workers to be able to come into our sector.
Thank you. The next question is from Judy. What are the specific plans for improving transparency and accountability? How will we as family caregivers have access to information, and what information? I'll open this to the floor for any panelist who would like to answer.
I can jump in a little and pointing, I think, to a lot of the initial steps, and we know more is needed, but supports, for example, like with Caregivers Alberta, we know that there are consistent pieces of information that's required. Alzheimer's Society as well, for caregivers who are supporting individuals with dementia. We know there are consistent needs and questions. And so I think what our goal needs to be going forward is, how do we streamline the access to that? We're working about sharing information through more consistent platforms, and again, consistency through United Way and a senior serving sector has been one way to have more consistent tools and resources and messaging. Even being able, for example, to call 211, which is connected to United Way, to have a consistent access to those. There are amazing resources across the system, but they're just not easily and readily accessible. And I think looking at supporting that navigation through tools like 211 or United Way backed platforms to provide that navigation resource, as well as other specialized platforms like Caregivers Alberta and Alzheimer's Society with their different tools, which again can be referred to through 211. I think that's what we need to do, is bring the resources all in one place ultimately going forward. And that is the work that government's undertaking on the back end.
The only other example I may add is when MMP was doing our report, we look at way other countries try to make the system transparent. And it is very important when someone is selecting a facility that they know exactly the feature of the facility. So in many states in US, if you want to select a facility, you can just type in the postal code, whatever they call it zip code. And then their staffing pattern, the number of staff, RN, LPN, the facility inspection report, the number of violations, the programs are all listed in the website. You can go in there and check it out yourself. So I think what MMP would recommend is that the whole idea is to empower the caregivers and the resident to choose where they want to live, but which facility they prefer. This transparency and availability of information to the public and to the caregiver is important. And using technology to do that is one way of doing it. We do have the information now. It's just to make it available. And as Evan said, I think the government immediately accepted the public reporting recommendation, MMP, and there will be a lot of work still need to be done to improve the case navigation, because our system is very complex to the clients. But I think we are in a very good start, but there's a lot of other things we could do as well.
Just highlight and building on exactly that, we did just launch an enhanced continuing care directory. We worked with Wayne and the ACCA, along with ASHA and the Kristen Health Association, to be able to advance a new directory, exactly that, put in your postal code, and instead of just a narrow list of AHS facilities that were available before, now it's broader to licensed facilities, whether it's publicly funded or not, to have access to all of those resources. That's so critical, Vivien. So much on the navigation side is access to information. Never mind getting in the door, it's even knowing where to start. And some tools like that are so critical to provide all the information in one place. And so just Googling Continuing Care Directory Alberta, you'll find that through the AHS platform.
I'd like to just jump in too. And so to enhance that and make it more usable, we've got some really serious data gaps we've got to fill, because you can only put up what we have data to put up. And I think that we need to evaluate it with families and the public, because is this what you need? Did this help you? And we need to look at all the unintended and intended consequences that might result. And people need to know about it. Those of us who've started navigating through the system at some point in the last years, no matter whether you're got nothing to do with health or you're a healthcare worker of many years, it's overwhelming and frightening because, of course, usually we start navigating about 3 hours before we need to make some decision. So I think what Evan talked about is critical, but I think we've got to build it and evaluate it so that it becomes really responsive to people, and that will also drive up quality, but it will not drive up quality without cost. I think we have to keep remembering that we have to always think about how do you resource facilities who might be struggling.
Thank you, panelists. I believe we have some time left for any closing questions from Marlene.
Thank you. I wanted to just pick up on the thread of the conversations that we just had before I asked my final questions. The conversation about transparency, about information for individuals, clients, residents, their caregiver, yes, benefits a lot from technology. And there's some comments about how we can make sure that that is really user-friendly. Second, however, the utility of that technology seems to me to rest in the attitudes and the practices that we bring to that. And I just want to say, this is another example of leadership in Alberta. And I refer you to the U of A's work around competent education and the competencies for caregivers in providing person-centered care. So important, because we have to develop new understanding and new practices. And third, it brings us to the question of the systems and processes within which people work and within which we engage each other. So therein lies the opportunity and the importance of many partners looking together at this very fundamental change that people are asking for. So that's just a perspective of the opportunities and work underway in Alberta. So my final questions to the panelists. What is the most important lesson learned from other countries and governments in making the changes envisioned in the MNMP report, which is bigger than the continuing care system? It's for the overall and a future of healthy aging and quality of life as we age. So I open it up to our panelists, the most important lesson you have learned.
Maybe I can start. The most important thing I have learned first by doing the MMP report, as well as reviewing the literature. First of all, I do want to acknowledge is privilege to be able to read the comments of 7,000 Albertans and caregivers telling the MMP surveyor as to what the system they want and their personal experiences right now in the current system. It is a very humbling experience. I think any people design a system, the most important that we learn is listen to the public, listen to people what they want. But more important of all is to develop a long-range vision and be open as to the involving the public to choose a direction of change. The country I admire most in Europe is Denmark, is regarded as the gold model kind of seniors care. In 1988, while the rest of the world trying to build more beds, their legislature decided the public want to stay at home. They actually passed a law to say it's illegal to build long-term care beds in 1988. And since then, they have been beefing up the home care program. They have prevention home care program, and they make the home care program so flexible. They told me, by the way, I did a study tour to Denmark. their home care people, when they interview staff, the first question they ask, they don't tell people this is what home care service we provide and this is what service we don't provide. The first question they ask is, what do we need to do to make you to be able to stay at home? So it's a different orientation in questions and an approach for care. So this is what I have learned.
Sure, I could follow up and jump in. I completely agree, Vivien, with your comments. And I think from a government perspective, one of the most essential elements is to actually work as a broader community of supports. And that's something that we've seen throughout COVID that's so important, is to work hand in hand with operators, with care associations, with residents, with families, and really in real time, test and respond. We had to do this so actively throughout COVID as it was related to visitation restrictions and others. And I think we've developed more robust mechanisms for engagement, for connections and responsiveness on where we need to do things differently. But building on that, I think it's so important coming from the Ministry of Health perspective. We can't just look at aging and continuing care through a health lens. And it really needs to be through a broader community lens, looking at roles that technology provides, roles that social services organizations, that family members all provide, and how do we bring them together differently? I think looking more comprehensively than just a case manager in a facility, and that's your connection point with supports, that's overly simplistic, and we need to move beyond that to provide more comprehensive resident and client-based care, as we've talked about going forward. And so I think partnerships are just so critical, and that's why these types of forums and the ongoing work with AAG and others is just critical to build that responsive dialogue for government to listen and channel that enthusiasm going forward.
I'll jump in. For me, I think it's that to be successful, we have to drive hard from values. That has to be where we start. And with that, hand in hand goes with what people want. And to Evan's point, often in health, we fancy that we can provide the expert opinion, which will, of course, will be the right one. And of course, it often isn't the right one. It's the expert opinion that we come with years of baggage with. It's not that the experts can't contribute, but I think it's driving from values and not saying, oh, well, we can't do that, that'll bankrupt us. Saying, how would we do that? What would it look like? Maybe we'll never get to Denmark's state of no long-term care, but we probably can reduce it dramatically. And then what does it look like? Could it look like a green farm where people stay mobile and still interact until a few weeks before death? And then they die quite quickly, which probably would be most people's preference. Whether it's a green farm or a greenhouse, or, I mean, there's 100 models out there, and not saying, and I think that successful countries have a value-driven and person-centered directive, but they also have some variety. Like, maybe certain models will work in rural Alberta and others are needed in the urban centers. So, but if we don't drive on values and what the public wants, because the public actually knows what they want. Old people or people who are facing old age know what they want. So I think those are the two things that I've learned, that we have to say, how can we, not, oh my God, we can't.
So a final comment from our group of speakers. Wayne, as you think about what excites you the most about going forward?
Thanks, Marlene. A recurring theme throughout all the speakers today was about this transformation of continuing care is complex. We've heard about the need to enhance the quality of care for our residents and seniors in the province. We've heard about the fact that we need to ensure that we have the right number of highly skilled workers available to be able to provide that quality of care. And Evan was speaking about the need for a sustainable sector as we move forward. So these are all very complex issues, but I'm optimistic, and certainly, we're very optimistic when we have a framework within the continuing care review recommendations to work from. And we've already seen some major strides forward. And I have to say that the continuing care legislation that was just introduced, we're the only jurisdiction in all of Canada that has it all under one act. And that is going to, address so many issues in terms of accountability, in terms of efficiency, and it's all of those kinds of things that will help us move forward and actually transform this, this continuing care sector. So we're really excited to be part of this series, and I look forward to the remaining seminars as we go forward here. Thank you.
Thank you, Wayne. So this does conclude our first webinar. There's some follow-up here from this webinar. One, you'll be getting a post-webinar survey for your input. Second, we will have the transcription of the Q&As, and I see many important areas for us to follow up on and get information back to you. Third, there was the question of the slides, which we have to review. The best place to follow the follow-up is on our website, and please go there. We will be serious about following up. The second thing is, this is number 1 of 8 webinars. Stay tuned. May 4th, the registration will be out tomorrow for the second foundational session about the rest of the story of transforming to an integrated community-based senior serving system, and then followed for the next 6 months into allowing for vacations in the summer and Christmas. We will have improving the working environment for senior services workers in June, then implementing cultural change to achieve quality of life for older adults in September, shifting resources to the community, building flexibility of community services and some of the client-directed options you heard about, October. Then in November, a focus on housing models and innovation there, including the small homes, that's November. And then after Christmas, policies and services to support caregivers, and then use of technology. So these are topics of importance to a journey for change. Really look forward to helping you have the information you need for action from where you are, and to your participation in the collaborative change initiatives that we have in Alberta. Thank you very much for your attendance. We look forward to your continued input and to your participation in our journey over the next 2 years. Thank you.